afternoon, everyone, and welcome to the Australian Institute of Health Innovation seminar series. This is an event that we've been looking forward to for quite some time. Professor Geoff Delaney is the Director of Cancer Services in southwestern Sydney, looking after a huge population in the southwest, based at Liverpool. He's a long-standing colleague and friend of the Institute's, and in fact, you've co-published with Enrico Coira, as I understand it, and Annie, and you and I are trying to get a grant at the moment, so we're hopeful of the NHMRC recognising our efforts to get a grant. We've known of Geoff Delaney's work for a long number of years. He's a fellow health service researcher, like many people here, but there's a bit more than that. Many of the people here are researchers, and that's what we do full-time for a living. Imagine if you were to add to your portfolio of responsibilities that you also had to run cancer services for more than 1 million people. And imagine also if you were, in addition, a clinician as well, actively seeing patients. Sounds like your job suddenly became easier in comparison to what Geoff Delaney does. So anyway, enough from me. I'm only here to warm you up and get Geoff started. So could you please welcome Professor Geoff Delaney?
So thank you, Geoffrey, for the very nice introduction. Very nice to see people here that I've worked with previously. Nice to see Tilo here as well. And I have given part of the presentation I'm about to give some years back as well, but I thought that I'd give an update of where we're up to. So being aware of what the Institute was about, I've decided to choose to talk about 2 programs of work that I'm heavily involved with. One is around evidence and getting evidence into practice, something that this institute is well known for. And the other is the electronic capture of data, another thing that this institute is very interested in. So hopefully this will resonate with the audience. So the first presentation is going to be talking about designing optimal pathways of care, or evidence-based pathways, comparing it to actual practice, and how that helps in planning future radiotherapy services. And the second is to talk about a project that we're doing, collecting electronic data on patient-reported outcomes. Firstly, to improve the collection of data. Secondly, to actually drive better care, and particularly better self-care of patients. And thirdly, to systematise the support of patients and linking the support of patients to the evidence as well. So trying to force evidence to be used wherever possible. So firstly, the optimal care in oncology. I'm just a cancer specialist, so I don't work in other medical spheres. So all of this today is about oncology. But I think you could find that the messages that I leave with you today hopefully will resonate across a broad spectrum of any chronic disease, really. So this kicked off as a PhD of mine, actually, about 15 to 17 years ago, where we decided that we were going to find in the literature every indication there was for radiotherapy, where radiotherapy was superior to other treatment or no treatment, based on an improvement in survival, local control, or better toxicity than a competing treatment. And we would only apply it to those patients that were suitable, so patients who were fit enough and didn't have serious comorbidities. So if we take this example tree, if we take an example cancer, and let's assume there are 2 states of the example cancer. You can have localised cancer and you can have metastatic cancer. And let's assume in the localised disease you can have patients of good performance status and poor performance status, and likewise in metastatic disease. And let's assume the evidence suggests that patients with localised disease of good performance status, we would recommend radiotherapy. And let's assume that we don't recommend radiotherapy for unfit patients. And equally, for those with good performance status metastatic disease, there's an indication for radiotherapy if patients have symptoms for radiotherapy. So just a nice, easy decision tree based on evidence. Now, if you know the proportions of these patients, so let's assume in this state that 80% of patients have localised disease and 20% have metastatic disease, and of the localised disease patients, 70% have have good performance status and 30% have poor, then just by simple multiplication of each of the nodes, you come up with the fact that 56% of patients are represented in this arm, and 6% of patients are represented in the other radiotherapy arm. So if you add them together, 62% of patients should get radiotherapy. Pretty simple. So this is one of the trees. This is rectal cancer. So you can see there's a few more nodes than the simple example, but it's not that much more complicated than what I showed you. And we divide decision making around the delivery of radiotherapy largely around patient stage. And the beauty of that is that we know these stage distributions quite well through the cancer registry. So all these numbers that sit under each branch represent the proportion of patients who have that stage of disease. And if we take this example, if a patient has radical surgery, then we don't normally give radiotherapy, but we would if they develop a recurrence. So this tree, that ends in a 1. I'll use the laser, that might be better. So because we're going to give radiotherapy in this group, this tree ends in a 1, radiotherapy yes. But if patients have stage T2N0, radical surgery and no local recurrence, they will never get radiation treatment. And these numbers represent that times that times that. This number is that times that times that. And so if you add up all the proportions where radiotherapy is given, you come up with a final figure for the proportion of all rectal cancer patients who should, at some time during their lifetime, receive radiotherapy. And it's 58%. So that's rectal cancer. This is the whole tree. So this is 23 A4 sheets of paper taped together, and that's my PhD. It's very hard to mail. But you can see how complex it becomes once you do the trees. And we use this fabulous bit of software called Triage, which allowed us to be able to do all this computerised, but we thought it might be fun to print it all out and tape it all together. And so during this PhD, we examined over 1,000 pieces of evidence. We constructed radiotherapy trees on 23 different cancers, so rectal cancer would count as one of those. Those 23 cancers represent 98% of all cancers, and we worked out that if you had a population of patients of standard Australian patients, 52% of them should receive radiotherapy during their lifetime. And that was useful because up until then, the government had been using 50% as a guide to predict how many machines were required. But that was based on really guesswork by the experts. And it was surprising how close it came to the actual figure. So that was way back in 2003. So that just acts as background. We've now updated the trees for 2012. And the reason for that is two things. The proportions of distribution have changed over time. So, for example, early prostate cancer has become much more prevalent. And secondly, the utilisation of radiotherapy or the evidence for radiotherapy has been refreshed. And so some of the cancers have got new indications for radiotherapy, and some of the cancers no longer recommend radiotherapy because of an emerging lack of evidence or evidence of non-effect. And so you can see that there's some minor changes for each of the different cancers, but overall the number has gone from 52% down to 48%. And it's a pretty easy exercise now to just keep going and updating this whenever new evidence becomes available. And it's also a useful model if you think that a new modality is about to happen that will alter the way you deliver radiotherapy. You can easily plug it into the electronic tree and within a couple of seconds work out what impact it will have on the future radiotherapy needs. This just shows the changes in radiotherapy between 2003 and 2012. Now, when you compare that to actual utilisation, so if the optimal utilisation is up here at 48%, this is data for all the local health districts in New South Wales. None of them achieve 50%. And in fact, southeastern Sydney looks like they achieve closest to the 50%. But interestingly, and perhaps not surprisingly, the concentration of linear accelerators in the district determines or it predicts for the use of radiotherapy. So these places down here are all the country centres, that did not have any radiotherapy. So for those patients to get radiotherapy, they had to travel to one of these centres. And so not surprisingly, their rate is around 32%, all the way up to about 40% for some of the metropolitan centres. And so this was fairly powerful data to be able to suggest to the ministry that if you build it in other centres closer to the patient's home, you're likely to be able to improve the use of appropriate radiotherapy. So we did a separate study on New South Wales and ACT data from 04 to 06, where we linked a whole heap of different data from different data sources to look at the radiotherapy utilisation at the individual patient level in New South Wales. So the aim of that study was to calculate the actual rate, identify the factors that affected radiotherapy utilisation, and quantify the geographic variation. So we got source data from radiotherapy departments, radiotherapy management information systems, and from what's called the RMIS report, which is a report published by the ministry. We started with 43,000 data set items, individual patients in the radiotherapy data set, and we ended up with 25,000 that were able to be evaluated. And that's cut off, but I think it's 108,000 different cancers registered during that period of time. So all the green dots are patients who had cancer and had radiotherapy in New South Wales 2004-2006. All the red dots are patients who had cancer and didn't have radiotherapy. Now, some of those will be appropriately not treated, but some of them will be appropriately treated. And obviously you can tell more about the rural patients because they're more spread out. There are red dots all the way through here as well. They're harder to see. And we then calculated road distance for each patient. And once again, perhaps not surprisingly, we've been able to quantify the fact that the effective travel distance of radiotherapy was significant. In that if you were close to the centre, you had about a 27% rate. But notice the actual rate in New South Wales in this period of time was actually only about 27%. So only about half the patients who should get radiation actually received radiation. And it incrementally dropped the further and further away you got from a radiotherapy centre. We were hoping to see maybe an inflection point where daily road travel and then a big gap if it was, say, 100 kilometres or more, where people go, well, stuff it, that's just too hard to do on a daily basis. But it's really an incremental drop rather than having a watershed line. And what we've now shown, what is shown on this graph, are all the new country centres. And actually, all the new country centres have been built between 2006 and 2010. And we actually think they're all in pretty much the right spot if you look at our analysis. And we hope now to go back to the data and look 5 years down the track after these centres are built, what effect building these centres has had. There are lots of issues with the study. Anyone who uses data in New South Wales will appreciate this. Anyone like to guess how long it took for ethics and governance? Any guess? 12 months. Any higher? Higher? 3 years. So a PhD student started this project, and at the end he was ready to write up a project on how impossible it is to get access to data in New South Wales. So it took 3 years, because at that time you actually had to go to every single local health district and get approval from the Director of Cancer Services and the Chief Executive Officer or the Delegate Data Custodian. We then had to go through multiple ethics approvals, both private and public. They all had opinions about the project. It led to lots of amendments going back and forth. I'm sure you can appreciate all of this. We're about to do another study very similar to this where we're actually delighted it's only taken 12 months. So things are improving. There are lots of obstacles in collecting radiotherapy data, despite the fact that radiotherapy is largely technical. All the information is in the information system, you just need to extract it. But we've identified a whole lot of problems with the data that hopefully will be addressed over time with the assistance of the ministry. And it's important because radiotherapy relies on very expensive equipment. Every linear accelerator costs between $3 and $4 million. And so it's important that the government get the distribution of radiotherapy departments right. And so the data that we've been able to provide not only has helped the planning of radiotherapy in New South Wales, but it's actually been used as a model throughout Australia, throughout some countries in Europe and the United Kingdom. And I'll show you some work that we've done for low and middle income countries. We've also done an analysis comparing the estimated optimal radiotherapy utilisation rate versus the actual radiotherapy utilisation rate to see where the big differences are. And this graph hasn't come out well with all the cancers listed down the bottom. But you can see that there are some cancers with substantial differences between actual and optimal. So the question arises, is the problem the evidence is not believable, or are there other barriers to patients getting evidence-based care? We've also looked at the range of optimal utilisations that might occur in different countries. So we've plugged in different countries' demographic data regarding cancer stage. So we've used Belgian data, Dutch data, Poland and Slovenia, all of which have got decent cancer registries. And we've plugged their data into our model to show that each country has slight variability in actual rates, depending on the stage distribution and the distribution of each of the different cancers. But it's a nice model now where you can really play with it quite easily. So this unfortunately doesn't come out, but the next slide will show the same thing. But a European group have been working on using our model to develop the standards for radiotherapy planning for the European countries. And what the graph is supposed to show is that we've calculated the optimal radiotherapy utilisation rate for every cancer, for every nation in the world. And this one just shows the low and medium income countries. So the high income countries are in blue, but the lower income countries, we've actually gone and done some quite detailed planning to try and help with going to their governments to start arguing for radiotherapy. A large number of African countries have no radiotherapy. The number of linear accelerators needed in China is huge. It's like 200 or 300 machines now to meet the shortfall. So there are some countries that are way behind the curve. Interestingly, the only country in the world that's oversupplied with radiotherapy, any guess? The USA. So if you look at this graph which looks at the deficit, the countries in red, so the USA, have met demand, and the countries in dark blue, such as Russia and China, and some of the South American and African countries need more than 200 machines. And now that there is a large workforce working under the International Atomic Energy Agency to attempt to advocate for the delivery of radiotherapy in low and middle income countries, and there's now an economic model attached to our modelling to suggest that firstly, there is an economic benefit by delivering radiotherapy, because a lot of the cancers that occur in low and middle income countries are often in younger people, so people of productive age. And we were able to project, based on the cancer projections for each country, what the cancer cases requiring radiotherapy would be out to 2035. And you can see that as sanitation and the treatment of other potential lethal diseases in low and middle income countries improves, that the need for radiotherapy goes up, because these patients then live longer and then develop cancers. Now, we've done a lot of other work in the modelling. Time doesn't permit me today to show them all, but we've done trees on optimal chemotherapy, brachytherapy, genetics, screen-detected breast cancer. We've now looked at survival benefits. So if you're not giving radiotherapy to this population, what's the survival detriment by omitting radiotherapy? Adaptation to low and middle income countries, palliative radiotherapy, the use of fractionation, so how many actual treatments are required in a country, not just how many machines. And now we're working on projects such as more work on travel distance. We're looking at the survival and local control reductions that would occur if you did not receive radiotherapy or chemotherapy, and we're integrating it with economic models to look at the health economy cost of the omission of treatment. And lots of peer-reviewed publication. I didn't intend you to read that, but just to show that there's lots of publications in the literature from our team on all the various different aspects of this type of work. This also shows the survival. This is some of the preliminary work we're now working on around survival benefit. And not surprisingly, the greatest survival benefit, so this is percentage of cancer patients with a 5-year survival benefit from radiotherapy. Most of them gain the most benefit in the lower and middle income countries. And so the best investment worldwide is going to be radiotherapy in those countries. Okay, so that's the end of evidence-based care for the time being. Happy to take questions at the end. I thought I'd spend 20 minutes talking about this project, and this project will resonate with a few people in the room who have been involved in the initial setup of this project, and we've learnt some things along the way around the Healthy Me project that we collaborated with Annie and Enrico. Patient-reported measures to improve the quality of life of people with cancer, utilising consumer engagement and patient-reported measures to drive system improvement and system redesign. But it's really come to the fore in oncology when this paper was published in late 2015, which was a randomised clinical trial where the intervention was to collect and report back to the clinicians electronic patient-reported outcomes in a cohort of patients receiving chemotherapy. So everyone was receiving chemotherapy. Half the group had their patient-reported outcomes presented back to the clinician, half the group didn't. Now, not surprisingly, health-related quality of life improved. So the clinicians were more able to satisfy the patient needs, is the presumption. There were less ED admissions, presumably because the toxicity of the treatment was being better addressed in the clinic. But the most interesting thing, I think, is that there was a 1-year survival difference. So what that probably means, and that it goes into great detail in the discussion, but I would agree with their argument, that patients were more likely to complete their chemotherapy because they were more able to have their symptoms managed appropriately by the team than people where the team weren't appreciating how sick the patient was. That's certainly the discussion that's going on in the oncology world about this landmark paper. This is an American study. Now, we were setting up PROMPTCare while this was happening because we were actually thinking about whether or not we needed to set up a randomised trial. And you could argue perhaps we need to set one up in Australian conditions, but we elected not to. We elected just to implement an electronic system. The other challenge for a cancer director such as myself is that with cancer survival rising and cancer incidence rising, the follow-up care for oncology is just getting enormously ridiculous in terms of cost to the taxpayer, but also just in terms of space in the clinic and availability of clinical staff. And in actual fact, if you look at the evidence, there's not a lot of evidence to support specialist care, but we all do it. And there are lots of different reasons why specialists do follow up, but a lot of the evidence actually shows it's an absolute waste of time, both for the patient and the clinician. And in fact, some studies, including one of our own, shows that having follow-up in a clinic actually provokes anxiety, coming back to the clinic and being reminded about their cancer. And there are very good models that have been shown in randomised trials to work just as well with either GP-led follow-up or nurse-led oncology follow-up. So one of the arguments that clinicians use is, oh yeah, but we need to collect patient data. So this is meant to try and partly address that and also identify those patients who perhaps need to come back into the system if we're going to let them go. So it's trying to provide that safety net for clinicians who feel nervous about letting go of follow-up. So the background and rationale of this study is that if there are significant clinical benefits of well-designed electronic patient-reported systems, then why isn't the practice widespread? And in fact, we have made several attempts electronically to collect patient-reported outcomes, but we've never been able to get it as business as usual. And the main reason why is because, in my opinion, is that we always set it up as a standalone system. So you'd see a patient in the clinic, you'd open up your electronic record, then you'd quickly open up the electronic patient record, you'd have to find the record in both, and then you'd have to look, and already a minute or two of the consultation is over. And so the clinical staff really needed it impregnated into the electronic system. So our attempt, and I think that was one of the difficulties with Healthy Me as well, is that it was yet another system for clinicians to look up. So PROMPTCare is the first Australian integrated e-health platform, and the important word there is integrated. So it's integrated into our electronic record. And this has been funded very generously by the Cancer Institute and by Bupa. And here are some of the team below. The team is actually a mixture of male and female, but Afa, who's the lead on this project, chose this picture. There are three basic components to this project. There's directing patient to evidence-based self-management tools. There's implementation or facilitation of clinical care, and there's the provision of data for research. And I'm not going to go into that further, that's fairly self-evident. If we collect lots of patient data, it might be useful in the future. So what I'm going to walk you through is the self-management and the clinical care side, because what we need to do in a system like this is we need to make it so important in terms of patient care that the clinicians use it. Otherwise, we have yet another electronic system not being used. So the first step was to decide which patient-reported outcomes. And when you look at the literature, there's a vast array of patient-reported outcomes. And when we actually had the first clinical advisory committee meeting of about 20 different clinicians, I swear at one stage during the meeting we decided on 450 patient questions, and it was going to take them 7 hours to complete the questionnaire. And so there was a real debate going on about, you know, how many is reasonable for the patient, what sort of questions are we most interested in. And so we used largely these criteria, that they need to be simple, brief. We had patients tell us themselves what they thought were most important. The tools had to be reliable, valid, and responsive to change. They had to be easily scored and interpreted, and we chose also for them to be free to be used. Some of the questionnaires that are available, you actually get charged to use them. And we thought for this to be widespread, in widespread use, that would be an impediment. So rightly or wrongly, this is the group of patient-reported outcome tools that we've chosen to use in the first instance, but it's the type of system where you can actually chop and change. And in fact, one of the discussions at the moment is whether to throw in a different questionnaire with patients at a later time point. So for those not familiar, distress thermometer is looking at a level of anxiety for patients. Edmonton Symptom Assessment Scale is looking at a variety of symptoms such as fatigue, nausea, supportive care needs. Screening tool number 9 as well is looking at what other needs the patient has. Are they financial, social, emotional, spiritual, and so forth. The other big argument was how frequently should we ask patients to do this, and we're still playing with this a bit. At the moment, patients are filling out assessments approximately monthly across the patient journey from the start of their treatment all the way through into survivorship. And we're now starting to phase patients from doing it in the clinic waiting room to doing it at home via email. We also had to develop algorithms to guide clinical care and self-management, because there's lots of self-management tools out there. So we had a clinical advisory group sit down and construct all these different algorithms that if a patient scores above a particular threshold, then we're going to deliver this self-management tool. And if they score over that threshold a second time, we're actually going to deliver a different intervention. What are we going to deliver to someone who has no scores over threshold? So that debate also occurred. And we came up with 15 actionable recommendations developed in the back end to drive the evidence-based clinical care, and I'll show you that a little bit more here. So if a patient has no clinical breaches, in other words, they've not scored any alarming scores, then they get an email telling them about how to maintain their wellbeing. So they're still sent to a website that has some information about how patients in general should maintain their wellbeing, but there are no clinical recommendations. If a patient has a first clinical breach, the patient gets sent what are called Tier 1 self-management resources, and I'll show you them in a minute. And the clinician gets feedback, and there are some clinical recommendations that are generated, which I'll also show you. If the patient scores a second breach, then there's an escalation process where the patient is actually asked to come back into the cancer centre, because clearly there is something wrong. Now, I don't intend you to read all of this, but just to show you that in the back end, there's all these different outcomes that are possible. with particular thresholds, and these are the recommendations that we have designed for each threshold breach. And so emotional well-being, there's a whole variety of different scores in some of the surveys that would lead to a recommendation if scoring above a certain score, and these are the various recommendations. The details of the recommendations is not important, but just for you to get a bit of a sense that there's quite a structure behind this. It's not just sending patients off willy-nilly depending on scores. There is quite a lot of evidence, although the evidence around threshold scores and what threshold you should send patients to one thing or another is lacking, and that's something that we're hoping to address with some of our research. Okay, now I mentioned earlier it has to be really important to the clinician. If the clinician is going to use this, there needs to be a way in which you deliver the information to the clinician in a very digestible format. So when the patient comes into the clinical consultation room at the moment, or if the patient is actually doing them remotely, the clinician clicks on one button and this automatically generates the report. The report is broken up into different sections. This yellow bit here is all the thresholds, all the scores that are over threshold and what the recommendation is. So we've dummied this one up for the patient to have a fair few problems, but each problem has the problem and what the recommendation is, right in front of the clinician. And when I say clinician, that could be a nurse care coordinator, a nurse manager, or a doctor, or an allied health staff member. It doesn't always have to be the doctor. So for some levels it might be they need to go and see the clinical psychologist, or they've got some social work problems, they need to go and see the social worker. Anything in red is high. So once again, if you print this out and there's nothing in red, then at a glance you can tell that this patient's going pretty good. But if you see lots of red, you realise this is going to take a while to sort through. But what it does is it concentrates the clinician on the problems. And a lot of these problems, historically, have never come up in a clinic consultation because patients don't want to bother the doctor. The other report that doesn't get printed automatically, but you can print them in another part of the system if you so desire, is a longitudinal report. So these are the dates down the side, and the red ones are where the patient scored high. So what you can see over time is whether or not your intervention is actually making a difference. And a lot of these interventions so far have not really been tested in a large cancer population. So this will be quite a valuable tool to evaluate interventions over time. And some of the scores, maybe you can't do anything about it. If a patient's having chemotherapy and they're feeling fatigued, there are a limited number of things that you can do to actually improve that fatigue other than just to support them until they complete their chemotherapy. But at least you know that it's still an issue for the patient. The other important thing is that, as I said earlier, we're trying to push a lot of the less important care, and I don't want to make that less oncologically important care, to the general practitioner. So we actually automatically generate a report for the GP at the end of clinic that also provides the recommendations. So, and we're working with the GPs at the moment to work out how we systematise that so the GPs are very happy to take over and look after the majority of these ongoing issues. There is also a link to the Cancer Institute evidence-based guidelines for the management of cancer patients. And there's also a direct number to the cancer centre. So if the GP says, no, I just can't cope with this problem, then there's a direct link back to the cancer centre as well. These are the emails that the patient gets. So if the patient has completed the survey, they get an email thanking them, and they get a link to the relevant email website. If the email is to someone with no clinical breaches, it goes to just maintaining wellbeing, which is just that website there. For one first-time clinical breach, they get a series of links depending on what the problem is. So this patient had a problem in emotional wellbeing, so they got sent to the emotional wellbeing self-management tool. If they had two problems, emotional wellbeing and fatigue, they'd get the two web links. So once again, we're trying to focus the patient information on their need. So that's just the emotional wellbeing website, and there's a number of links attached there. If the patients breach more than once or they breach very high, they actually get sent to tier 2 websites, which are much more, rather than just being text, they're actually tested self-management tools that have got a lot more content and a lot of video and so forth to more intensively support the patient compared to the tier 1. So we're trying to prioritise patients that have various different levels of need. We thought if we did this for tier 1, we might overwhelm some of those patients in tier 1. And for those with a second breach, they actually get all these websites, all these links, but it also identifies whether or not they need to come back to the clinic. And I think the next slide actually shows, the next slide shows that an email actually goes back to the caring team to say your patient has just clicked high for the second time or too high on one of the scores, and we suggest that you contact the patient. And some of these have led to a phone call and nothing more. Some of them have led to the patient coming back for another consultation. I don't pretend to be IT savvy, but one of the major challenges of this project was to enable patients to enter data directly into their health record. And so we had to go through the firewall. And as soon as you mention the firewall to anyone in IM&TD, they just freeze. They go, no, you can't go through the firewall. So this is a very basic IT structure, which I don't pretend to be able to describe to you, but anyone with IT knowledge will, I think, understand it better than I. But the important point to make is we had to work very closely with the IM&TD and with the IT advisors that we had about a system that was sufficiently secure to reassure the IM&TD department that, that the firewall was not put at risk by such an arrangement. I've mentioned the longitudinal PROMPTCare report over time. So like I say, you can look at various interventions, and you can also look at, if this patient's having chemotherapy, then you can look at the timing of these side effects versus the administration of chemotherapy. There are lots of things you can do with these data now that we're collecting them routinely. We've done a lot of focus groups around these products. So 100% of patients in the very first pilot, which was only 35 patients, found the time to complete the assessments about right. But you'll see that one patient actually took 2 minutes. So after they've done them a few times, they kind of just go in and find the questions that are relevant to them, and they don't answer a lot of them. And one thing I didn't show you on the clinician report, if the patient doesn't answer any of them, the item is struck out as opposed to a null. So at least as a null, so that at least we knew the patient didn't answer that question. It wasn't just the fact that they were answering 0. 96% of patients found the online assessment easier than completing a paper copy, and 79% of patients said that they'd answer more questions, and 21% said maybe, because we're trying to get a feel now for what would be an appropriate level of questionnaire asking of patients. Some text from some of the patient views. If PROMPTCare actually came up straight away and actually gave me a handle to express something that I couldn't figure out how to express to the person I was speaking to, and it prompted them to ask me questions. So that's pretty good feedback that we're actually achieving what we wanted. This patient had trouble expressing themselves to the clinician, but the clinician has taken that responsibility away from the patient by mentioning it back to them. The GPs are very enthusiastic. They're very keen to receive these types of data and very happy to work with us. Some of the more negative feedback is some of the self-management resources leave a bit to be desired, and so we're taking that on board. This patient said they had to hunt for something that was directly related to them. So we're going to have to tailor that more. Clinicians, a lady who I know has a very high level of anxiety, so I contacted her because I was surprised that she still had identified these factors, as I thought she had turned a corner. So it was good from that point to catch up with her. So I sent a letter to her GP notifying about that. So you would assume that wouldn't otherwise have happened. I would have an impression about a patient that things weren't going fantastically, but the clinical feedback reports give greater granularity and specificity. Looking at a report, if there were flags beyond the biological component of the cancer, it did make their consultations probably double in time. So if that was followed up by the care coordinator or the clinical nurse consultant, they had the time for it. There are lots of barriers so far. So we've recruited now over 300 patients to this study. It's a relatively easy study to recruit patients to. Patients are generally enthusiastic and accepting, but there are some barriers. So we've set this up in 4 cancer centres at the moment, which are Liverpool, Campbelltown, Illawarra and Shoalhaven. Firstly, 40% of the Liverpool population of patients don't speak English. So we haven't addressed that in this project, but one of the beauties of this project is that the next stage will be we'll translate these questionnaires into multiple languages. So for the first time, we'll actually be able to collect granular electronic patient-reported outcome information from non-English speaking patients. I mentioned some of the departmental barriers, such as IT. There's a bit of resistance from the administration staff about administering the questionnaires in clinic. It just slows down the waiting room a little bit, and it's about getting our head around the model. There have been occasional technology problems, although very few. Mosaic has gone down a few times, but not very frequently, but we have to think that through. The selection of measures and which measures are appropriately measured over time. Getting the model of care right, such as the self-management tools. The clinician variability in interpretation and response. So when talking to clinicians, some of them say that our thresholds are too low. We're potentially overdiagnosing anxiety, for example, so there might need to be some fine-tuning. I suspect the variability is more differences of opinion. It's certainly having it's having a positive and negative impact on the health service, in that more allied health consultations are being requested. So the allied health staff are actually pushing back a bit, saying you're overwhelming us, but it's actually, I think, a positive outcome, because it means that we're now identifying patients who should have been identified by using this system, but then trying to get them the adequate resource to be able to manage the patient is the next challenge. Tailoring the information I mentioned earlier, and implementing in other systems other than Mosaic. So we've been solely working in the Mosaic space, but there are other cancer information systems out there. But I think now that we've done this in Mosaic, it should be relatively easy to do it in other systems. Just a plug for the Ingham Institute. So the building on the right is the Ingham Institute. It is split into 5 streams, one of which is cancer. There's population health, there's early years, there's orthopaedics, and there's a significant amount of laboratory space in the building as well. We're hoping to get the second phase of building works approved for funding in the next few years. It's growing quite rapidly. Some of the research ideas that are potentially coming off the PROMPTCare project are listed on the left. There's a lot of work to be done in cancer survivorship, and PROMPTCare might actually be able to be the lever to get patients into appropriate survivorship projects. TCM is traditional Chinese medicine. There is some interesting work looking at traditional Chinese medicine for treatment of long-term chemotherapy toxicity, such as hot flushes or fatigue, that we're currently doing randomised trials in, just as one example. I think that's it. So what I hoped to do today was just give you a little bit of a taste of some of the projects that we're doing. Some of them will resonate with some of the work that you're doing here. Hopefully compare notes, and it might encourage further collaboration. So thank you for your attention. Wherever possible, we've accepted the validation and the fact that these tools are already validated, some of which have been used in clinics in New South Wales, for example, but paper and pencil. We wanted to get over that step to really do the IT project, if you like, rather than, yeah, that's probably another year's worth of work. We haven't got there yet. So at the moment, the big project that we're currently working on is we're working on what we're calling a discharge clinic. So we're hoping to change the model of care. One of the problems we believe is we've trained the patients to rely on us by our words and our actions, by getting them back, and even by saying to them, well, you can go and see your GP or you can come back here, you know, and giving them an option. Whereas what we're trying to do is say this is part of normal business. And in fact, there are some great models around the world where oncologists don't see any follow-up. So in British Columbia, they see no follow-up. Now that's apart from the occasional patient with a real oncological problem, but the GP does all the follow-up. So we think a lot of it is about changing the attitude. So that discharge clinic will look at all the prompt scores. It will look at the future patient survivorship needs. So let's say, for example, they're overweight, they smoke, and they're on hormone therapy for 5 years. So they will give some tools for the patient to stop smoking, to improve their diet and exercise, and it might even include enrolment into one of the exercise programs, and information about hormone therapy, and an appointment to come back to the clinic in 5 years' time when that hormone therapy needs re-evaluation, but with permission to come back at any time if they're suffering toxicity. That all then gets constructed in a draft care plan that goes with the patient to the GP, who endorses, yes, I'm happy with this, or no, they're not. That's the plan that's currently going through ethics for approval at the moment. And we'll run that project in a number of different sites. Not yet. So we're working with a health economist and we're going to do a case control comparison of patients on prompt care versus not to look at healthcare utilisation. So, and that's a very important point, because if we don't do that, then poor allied health are going to be overwhelmed with the work. And I should mention Tilo did some excellent work with Illawarra early on to get the data into Mosaic, which was the key to this project. So we engage clinicians early on about the model, but really what the model partly does is it takes the governance away from them. So as long as they're happy with the governance framework, they no longer are the ones responsible for enforcing the governance. So let me explain that a little bit differently. Anyone in the organisation now can refer the patient to psycho-oncology based on the distress score. So the clinicians have said, if the distress score is high, I'm happy for my patients to be referred. And so other members of the team are actually doing that. And it's not relying on a clinician to remember to do it or to feel that it's appropriate or anything like that. It's really saying we're embracing this model of care, and the institution as a whole is going to work towards implementing it. No, maybe that's a reflection of our department, I don't know. But
it's a general problem.
In four departments, we have not had very much pushback. In fact, I tell a funny story that when we went from 2 clinicians trying it to opening it up to everybody, I sent an email to all the clinicians saying we're now ready to go with PROMPTCare. And it's the only email in history that everyone has replied positively about anything I have ever said. Which tells me that it may be quite a powerful tool.
Yeah.
I'm not... Firstly, I'm not...
We can see it in your next book, I'm sure.
Firstly, I'm not sure we've won yet. So I feel very positive about the outcomes to date. The next step is the Cancer Institute have agreed to roll this out in New South Wales. And I think there will become some very interesting reactions. Maybe it's just the fact that we're preaching to a relatively cohesive oncological service at Illawarra and Liverpool. Maybe there are lots of other clinicians who wouldn't do what they're asked to do. So that's going to be an interesting next step. And trying to coordinate it at a state level will be very hard. I think there were 2 very important components to this project. Well, 3 actually. We had a number of false starts We had lots of different attempts, so we didn't give up. And we learnt from those attempts. There was a lot of planning involved, and the planning involved researchers and clinicians. I think that's probably the key. So we probably spent a year to a year and a half planning, looking at the evidence, looking at what we had, looking at what systems had worked, but also making sure that any IT solution was valuable on day-to-day care, not just some add-on. Part of the problem about quality improvement projects, I find, is you put a resource in, you do the quality project, everyone goes, great, it improved, and then they take the resource away. Here we're trying to actually leave the resource in place, which is the IT system. We will have some challenges around, it will change the staffing dynamic of a department, and we're collecting that data. Do you need an extra person in administration to actually administer the questionnaire? The interesting question, though, will be the health economics of it. If we can shift a lot of follow-up to GPs, we've saved the government an enormous amount of money. If I could get 5 extra staff, that will more than compensate for the huge cost saving of specialist care. So there's a whole lot of components, but I'm still not sure we're completely there.
Be very interesting to see when it rolls out then, whether it's whether there's a Geoff and AFAF effect
Yes.
at the local level,
Yeah.
which you could then
maybe
write a
there
paper
is.
and describe that.
That's
But
right.
if it rolls out,
That's
then
right.
you've
I
taken.
I can guarantee that nothing else I say normally works, so it's very ineffectual most of the time.
All right, we're going to draw this to a close, and thank you very much,
Right.
Geoff.
Thanks
You
for your
really have
attention.
given us some insights into research that, we do health, we're all health services researchers in
Yeah.
some form or another, but this is really interesting, as Enrico says, to see someone in situ doing this in a service. You've given lots of talks, you've travelled the world, but you do not have a gift from the Australian
Oh,
Institute
thank
of
you.
Health Innovation, which on behalf of the group we'd like to present.
Thank you very much. Thank you.